Okay, good afternoon. I hope you can hear me. My name is Dr. John Chan. I'm a consultant cardiothoracic surgeon at CVSKL Hospital, and I'd like to welcome you to our webinar today. So I'd like to thank CVSKL Hospital and Servier for organizing this webcast today on avoiding the major complications of hypertension. And I will share with you in the next 30 minutes some of the complications which I deal with as a cardiothoracic surgeon. Obviously, hypertension affects all the organs in the body, and the complications are huge. So I will focus today on the some of the complications which I see quite often with, and hopefully you'll find it useful and interesting. I'm told we have a mixed audience here today. On Zoom, we have doctors from various specialties, and we also have members of the public on Facebook. So I will I will try to explain some of the basic concepts as well, so that hopefully everyone will find this session useful. And at the end of this, I will be happy to take any questions. If you do have any questions, you could type them on Zoom or on Facebook, and I've got my colleagues here who will write down the questions and pass it to me at the end of the session. So let's get started. So as we all know, hypertension has an impact on mortality, cardiovascular mortality. And as we can see from this study, which was published in the Lancet some years ago now, that the lower the blood pressure, which is achieved, the better the survival for the patient. So on this vertical axis is the absolute risk of mortality from coronary artery disease, broken down to the different age groups. And you can see if we can get the systolic pressure as low as possible to about the 120 to 130 range, then we will reduce the risk of cardiovascular deaths. And if we look at this other study as well, you can see that the range of between 110 to 130 seems to be the ideal blood pressure target to aim for, whether this is measured in our clinics or by the patients at home. And you can see that the higher the blood pressure measured, either in clinic or in the outpatient clinic, the risk of cardiovascular deaths increase. So I think the importance of blood pressure control is well known to all of us, and this just provides some insights into the risk of uncontrolled hypertension. So focusing on cardiovascular complications of hypertension, because as we know, hypertension can affect the cardiovascular system, it can affect the brain, it can affect the kidneys, but obviously we won't be able to cover everything in half an hour. So we will focus on the cardiovascular complications. So hypertension can cause a progression of coronary artery disease and myocardial infarctions. For those with heart valve disease, it's often not appreciated that if you have heart valve disease, say a leaking aortic valve or mitral valve, then the presence of hypertension can actually accelerate the progression or worsening of the heart or of the valve dysfunction. So if you have got heart valve disease, it is important to control the blood pressure as well. And of course, hypertension over time can lead to left ventricular hypertrophy and heart failure. But today, I'd like to focus more on the progression of aortic aneurysms and dissection, because this is something which is very serious and which we don't often think about. But the presence of a small aneurysm can be controlled with good blood pressure control, but at the same time, if the blood pressure is not well controlled in the presence of small aneurysms, then they can lead to a progression of the aneurysms. And of course, if you already have an aneurysm, then blood pressure control is even more important, because in uncontrolled hypertension or high blood pressure, in the presence of aortic aneurysms, then aortic dissections can occur. So this is the aorta. So the heart is here. The aortic valve is here. It separates the aorta from the heart. So this part of the aorta is the ascending aorta. This is the aortic arch, and this is the descending aorta. So we will focus first of all on diseases affecting the aortic root, which is this part of the aorta, and also the ascending aorta, and then the aortic arch, and also the descending thoracic aorta. So last year or 2 years ago, I was involved in this research study which looked at the incidence of aortic disease in Malaysia, and it looked at all the research which had been done on aortic diseases in the country. So we have some insights on this disease in the country. There is roughly about 15,000 cases of aortic diseases in Malaysia from a population of 23 million. And the mortality from this is 5.2 per 100,000. So it is not as high as, say, coronary artery disease, but it is the third highest in Asia. And the annual years of healthy life loss is 73 per 100,000. Interestingly, there are different rates of aortic diseases among the different ethnic groups in the country, and it appears to be highest in the Chinese population. And if you look at studies in Europe as well and the US, there does seem to be a higher incidence in certain ethnic groups. So there may be a genetic component as well to the aortic diseases. It is more common in males, as you can see, more common in males compared to females, and it is more common the older you get, so that the incidence is 78 per 100,000 if you're above 70 years of age, but it's only 25 per 100,000 above 50 years of age. And this gives an idea of the number of aortic surgery we do in the country. Roughly, we do about 200 of these cases a year, and about half of this, slightly more than half, are for aortic aneurysms, and about 80 of these are for aortic dissections. And this breaks it down to the parts of the aorta where the surgery is involved. Most of it involves the ascending aorta and also the aortic root, and some of it the aortic arch, and a small number involves the descending thoracic aorta. So we focus first of all on aortic dissection. So aortic dissection is, as we know, a tear in the aorta. The aorta typically has three layers, and what happens in aortic dissection is that one of the layers of the aorta gets torn. Typically, this is due to high blood pressure, which is the most common risk factor for aortic dissection. A lot of these patients may also have some weakening of the aortic wall from connective tissue diseases such as Marfan syndrome, but by far the most common cause of aortic dissection is hypertension or high blood pressure. So as you can see from this illustration, a tear has occurred in this layer, and then blood tracks in between the layers of the aorta. So this is a very painful condition, and the most common symptom for the patient is severe chest pain or back pain, and it will be the worst chest or back pain which the patient has ever felt. So the history is quite classical: a sudden onset of severe chest or back pain. It can often be mistaken for coronary disease, for heart attacks, but the index of suspicion must be there if the pain is of sudden onset, is of severe, of great high severity, and is not improving with the nitrates or the GTN which you would give for angina. And of course, the main risk of this condition is that if it's not treated urgently, the remaining layers of the aorta may also tear. And if that happens, then of course the patient will not survive. And the other thing which can happen is the tear may occur with leakage of blood into the pericardium, causing pericardial tamponade, and that would again be a cause of mortality. And a third thing which can occur is that this is the aortic valve here. It can become incompetent. It can start leaking acutely, and the patient can then go into acute heart failure. So the symptoms of this condition is chest or back pain, shortness of breath, or a loss of consciousness. If the aortic dissection involves the arteries to the brain, then that can cause a loss of consciousness. So the investigation for this is by CT scan. And you can see on this CT scan here that there is a tear. This is the ascending aorta, and this is a descending aorta. And you can see that there is a tear involving both the ascending and descending aorta in this patient. The aortic dissection of the aortic root and the descending thoracic aorta can also be seen on echocardiography, but the gold standard investigation for aortic dissections is a CT scan. So if the dissection involves the ascending aorta, this part of the aorta, it is called a type A dissection. If it does not involve the ascending aorta and is limited to just the descending part of the aorta, then it is called a type B dissection. So generally, if you have a type A dissection, that requires surgery to replace the torn part of the aorta. If the dissection is limited to the descending thoracic aorta, this part of the aorta, then in most cases, they can be successfully treated with blood pressure control. So adequate blood pressure control is needed for all cases of aortic dissection. In the case of type A aortic dissection, they would require surgery. In most cases of type B aortic dissection, they do not require surgery. Most of these cases can be controlled with adequate blood pressure control. And for this particular condition, the best medication to use for blood pressure control is a beta blocker, because that will slow down the heart rate, and it will also slow down the force of the blood in hitting the aortic wall. So the first line treatment for blood pressure control in this condition is beta blockers, and only after you have maximized the dosage of beta blockade, getting the heart rate down to about 60, and if the blood pressure is still not controlled, then you can add other forms of antihypertensives. So this is an example of a patient at surgery. You can see this picture here is the aorta, which has been resected. You can see this is the aortic wall. You can see this flap of tissue, which shouldn't be there. This flap of tissue should be attached to the aortic wall. In this case, you can see it has detached. And behind this flap here is actually a hole where blood has tracked out of this aortic wall. And you can see there is hematoma on the outside of the aorta as well. So this patient had the ascending aorta replaced, and this is a Dacron graft. This is the new aorta which we would have stitched onto the torn part of the aorta. This is the heart here, and this is the arch of the aorta. So this is a treatment which we really need to do within as soon as possible. Once the diagnosis is made, surgery should be performed as soon as possible to save the patient's life. This is another example of a patient with an aortic dissection. Again, you can see the torn part of the aorta. Here you can see that the aortic arch is very involved and diseased. And so this patient needed the arch of the aorta to be replaced as well. And we have various types of graft we can use to suture onto the aorta to replace it. So this part of the graft would replace the ascending aorta, and then we have small little limbs here which we can join to the blood vessels supplying the neck. So after surgery for an aortic dissection, don't forget that in most cases, the aortic dissection is not limited to the ascending aorta and the aortic arch. It involves also the descending thoracic aorta. But at surgery, we've only replaced the ascending aorta and the aortic arch. So the good blood pressure control is very important because the patient still has a dissection of the descending thoracic aorta, the lower part of the aorta. So fortunately, in most cases, if we control the blood pressure adequately, then the descending thoracic aorta does not cause problems, and patients can do very well for many years after surgery with a descending thoracic aortic dissection if the blood pressure is well controlled. So that is very important. Now, if we do have problems with the tear or the dissection in the descending thoracic aorta, usually this will be many years later, then we have the option of treating this. And in most cases, this will no longer be by open surgery. Nowadays, we would do endovascular surgery to treat a condition in the lower part of the aorta, the descending thoracic aorta. So we can, through a small incision in the femoral artery in the groin, we can push up this graft and then release the graft in the descending thoracic aorta to exclude the dissected part of the aorta. This is a procedure called thoracic endovascular aortic repair, or TEVA. So in most cases of dissections involving the descending thoracic aorta, we no longer need to do open surgery. We can control with blood pressure, medications, and if some intervention is needed, say if the dissection is continuing to progress, then we will recommend an endovascular approach to treat the condition. So the take-home message is that aortic dissection involving the ascending aorta is a surgical emergency. Uncomplicated descending thoracic aortic dissection can be managed medically with blood pressure control. Complicated descending thoracic aortic dissection should be managed by TEVA, this endovascular treatment. So obviously you can see that aortic dissection is a very serious complication, and we have to try to prevent it from happening in the first place, because the problem of aortic dissection is the aortic wall tissues are all torn, so the tissues are very weak, so and that makes the risk of surgery very high because we do not have a strong tissue to suture the new graft to. So all of this increase the risk of the procedure. And also because in aortic dissection, the tear is not limited to just one part of the aorta. Usually it involves the whole aorta. So that means that very often perfusion to the other organs of the body, like the kidneys, the gut, and the brain may also be affected. So this is one of the reasons why the risk of surgery in aortic dissection is very high. So it is better to pick up problems with the aorta earlier. So one of the conditions which can lead to aortic dissection is aortic aneurysms. So these are conditions in which the aorta is already starting to get bigger, but the aorta is not torn yet. So so it is much safer to address the problem at this stage rather than to wait until the aorta is already torn or dissected and then try and do surgery to save the patient's life. So in this case, for example, you can see this is the heart here. This is the aortic root. This is the ascending aorta. So you can see that the aortic root and the first part of the ascending aorta is already much bigger than the normal aorta, which is about this size. So this patient has what we call an aortic root aneurysm, or a dilatation of the aortic root, and it measured 6 centimeters. And because the aortic root had got bigger, it has also stretched the aortic valve apart. So this patient also had severe aortic regurgitation. So at 6 centimeter, this patient was at risk of getting an aortic dissection if we just left it alone, even with adequate blood pressure control. So we would recommend surgery at this stage to replace the aortic root, and we can do this electively in a very controlled situation, and the risk of surgery in this situation is a lot lower than doing surgery when the aorta has already dissected. So these are the recommendations. In this case, this is from the European Society of Cardiology, that surgery is indicated in patients who have an aortic root aneurysm with maximum diameter of more than 50 millimeters for patients with Marfan syndrome. So Marfan syndrome is a connective tissue disease which puts the patient at increased risk of aortic dissection. So in patients with Marfan syndrome, we recommend surgery at a slightly lower threshold size, 50 millimeters. For most other patients, the threshold size is 55 millimeters if they have no other connective tissue diseases. But if they have connective tissue diseases like Marfan or a bicuspid aortic valve, then it's 50 millimeters. If they have Marfan and risk factors, so risk factors meaning if they have a family history of a relative who had an aortic dissection at a very young age, or if the aortic aneurysm has grown significantly in size in a very short period of time, then we would recommend surgery at a much lower threshold of 45 millimeters. So lower thresholds for intervention may be considered according to the body surface area of the patient as well, and the progression of the aortic aneurysm and other conditions. If, for example, the patient is planning a pregnancy, puts the patient at risk of aortic dissection if they already have an aneurysm. So generally, if a patient has an aortic aneurysm, we would advise them against getting pregnant. And if they do want to have children, then we would advise that they do have the surgery to fix the aorta first before pregnancy. So this is what we would do. We would typically replace the ascending aorta with an artificial graft. And as you can see here, the coronary artery is attached to the aorta. So we would have to detach the origins of the coronary artery and then suture back the coronary arteries into this new graft. So this is another example. You can see that the aorta has got a lot very big in this case, the aortic root, and you can also see that the aortic arch has also got very big. This is the innominate artery bringing blood to the right arm. This is the carotid artery, the left common carotid artery bringing blood to the brain, and this is the left subclavian artery bringing blood to the left arm. So you can see in this particular example, all of this would need to be changed. Fortunately, we have very nice graphs nowadays to make things easier for us. So you can see the ascending aorta and the aortic arch has been replaced. This is the connection to the innominate artery. This is the connection to the carotid, the left common carotid, and the connection to the left subclavian is there. And this particular graft has a stent also, which we were able to put into the descending thoracic aorta, because this patient also had an aneurysm of the descending thoracic aorta. So we have grafts nowadays which has made this surgery a lot easier for us to manage. So essentially, this is what the patient had done. She had the ascending aorta, the arch replaced, and a tube graft placed down into the descending aorta to exclude this part of the descending aorta, which was also aneurysmal. And this is her X-ray after the surgery. You can see that the stent in the descending aorta, you can't see the graft in the ascending aorta and the arch. In this case, you can see that she had further stents put all the way down into the abdominal aorta because she had a thoracoabdominal aneurysm. So we can treat this most of the time. If the aneurysm extends beyond the aortic arch, we would treat aneurysms further down in the descending thoracic aorta and the abdominal aorta with endovascular stenting rather than open surgery. But aneurysms involving the ascending aorta and the arch, we would still need to treat with open surgery because of the problem with the blood supply to the brain if we were to put a stent across these vessels. So this is another example of an aneurysm. You can see this is the aortic arch, descending aorta. You can see right at the aortic arch there is this ballooning of the aorta, what we call a secular aneurysm. This sort of aneurysm is at risk, at high risk of rupture. So we have to replace this part of the aorta. The challenge is, of course, the blood supply to the brain arises at around the same place. So again, we will also have to use the special graft to replace this part of the aorta with grafts to connect to the blood vessels to the brain again. And this is the picture at surgery. The graft is sutured, in this case, to the innominate artery and the aortic arch. So if the aneurysm involves the descending aorta, as we can see, we can do endovascular stenting. In most cases, we can do it. It's quite unusual for us nowadays to need to do open surgery involving the descending thoracic aorta. Most of it can be treated endovascularly by TIVA. So obviously, although open surgery of the aortic root, open aortic root replacement surgery, and open aortic arch replacement surgery is a much lower risk operation than surgery on aortic dissection. Nonetheless, it is still a big operation because if you can imagine, we have to replace the parts of the aorta which connect the heart to the brain. So if we can even prevent that the need to do the operation, that is best. So good blood pressure control is one way to do it. But if the patient has got Marfan syndrome or other connective tissue diseases, then the studies show that the aneurysm will progress regardless of how good the blood pressure control is. So, but if we can diagnose the aneurysms at an early stage, when the aortic root is just starting to get bigger, but has not reached the size where we need to replace the aorta, then we can offer this treatment option where we can wrap a supporting mesh around the aortic root to stabilize it, to strengthen it, and to stabilize it, and so avoid the need for a big operation. So this operation would not involve replacing the any part of the aorta, but it would just involve wrapping this cloth, this strong cloth, around the aorta, and then suturing it tightly so it will strengthen the aorta and prevent it from getting any bigger, and also prevent it from tearing. So this is a procedure called a personalized external aortic root support. And this procedure has to be customized for each patient. So what we typically do is we will do a CT scan of the aortic root, and from that we get very precise measurements of the geometry of the aortic root and the ascending aorta, and then we will send all these measurements to the company which manufactures this device, and they will custom made a wrap for us according to the geometry of the aortic root for that patient. And then they would send it to us, and then we would then wrap this around the aortic root at surgery. So this is what it looks like. It still needs open surgery, but it doesn't need to resect the aorta and replace it with another aorta. It just involves wrapping this strong material around the aortic root to strengthen it. So this procedure is not new. It's been around for some time, and I was privileged to be part of the initial team which actually invented this device. And this is the publication more than 10 years ago now, which we have published. And essentially, it shows the concepts behind it that we have measured by, in this case, by MRI scanning, and acquired the geometry of the aortic root. And from this, we can 3D print a scaffold, and through that, we can then manufacture the supporting wrap of the right shape to suture onto the aortic root. And these are the early results in the first 20 patients who had this procedure done. And the results are very good in that it showed that the aortic root, this is the size of the aortic root. The vertical axis show the size of the aortic root, and you can see that in two different time points, the aortic root diameters have been stabilized. And more recently, we have a longer follow-up now in the first 24 patients now at 6 years after the procedure. You can see that this graph on the vertical axis, it shows the change in the diameter of the aorta. So the aorta, this zero here is the size of the aorta at the time of the procedure. And you can see at follow-up, you can see the size of the aorta has actually got smaller. It is below this dashed line for the part of the aorta in which we had wrapped the mesh around. So we had wrapped the mesh from the aortic root right up to the proximal aortic arch, just before the brachiocephalic artery. So in the part of the aorta where we had secured this mesh, you can see that the aortic diameter has reduced in size and certainly has not increased in size. For the part of the aorta which we have not wrapped around, namely the aortic arch and the descending thoracic aorta, you can see that the aorta has continued to increase in size. And this is what we would expect because these are patients with Marfan syndrome and connective tissue diseases. The aorta would have a natural predisposition to continue to dilate. But fortunately, in most of these cases, although the aorta in the rest of the body continues to increase in size, it does not usually reach the size where it needs surgery. So the size of the aorta in the descending aorta, for example, it will continue to increase in size over the patient's lifetime. But fortunately, in most of these patients, it does not quite reach 50 millimeters. It may reach about 40 millimeters and stabilize at that size. So in most of these cases, we can treat it very well with either replacing the aortic arch and the ascending aorta. But if we pick up the condition early, we can then offer them the personalized external aortic root support to stabilize the aortic root and the ascending aorta and prevent it from getting any bigger. So as of October last year, you can see here that 258 patients have been treated with the personalized external aortic root support. This is data, worldwide data, 174 males and 84 females. The longest follow-up now is 15 years. 18 patients have had 10 years of follow-up. Most of the patients have had at least 5 years of follow-up. And this is the age range of the patients treated. This is a condition which affects the younger age group. So most of the patients are between the age of 20 to 40 years of age. And this is the range of conditions treated. Most of them have Marfan syndrome, which is a connective tissue disease. Then some have Lewis-Dietz syndrome, bicuspid aortic valve disease, and so on. The operative mortality is very low for this procedure, less than 1%, 0.4%. Survival at 5 years is more than 99%. Follow-up now extends to 15 years. In all the patients who have been treated, none of the patients have had an aortic dissection, and none of the patients have shown any progression in the size of the aortic root. And all surviving patients are living a full and active life. So this is the image from the first patient who had this procedure way back in 2004. He's still alive and well today, and his aortic root has stabilized in size. You can see it is bigger than normal, but it has not got any bigger with this support, with this PAIRS procedure. And it has stabilized it, and we expect the aorta not to increase anymore in size. The rest of the aorta has increased in size, but it has not reached the size where we need to do any intervention. And in this condition, it is important to maintain adequate blood pressure control. In these cases, there are blood pressure control by beta blockers and also by the ARBs and ACE inhibitors has potentially can slow down the rate of growth of the unsupported part of the aorta. So one patient passed away at 4.5 years, and a post-mortem was done. And the interesting thing is that at histology, you can see that this aortic root wrap had become incorporated into the aortic wall and had become part of the structure of the aortic wall. So suggesting to us that the aortic root wrap will over time become part of the aorta and contribute to the strength of the native aorta. So now, in the initial years, the procedure was only done in a few centers, but over the last few years, you can see the orange bars are the number of centers offering this procedure, and the blue bars are the number of patients being treated. So the number of patients being treated by this procedure has increased very significantly over the last few years. And as of October last year, there are 8 centers in the UK which offer this procedure, one in Belgium, 7 in the Czech Republic, 3 in Australia, 2 in Ireland, 1 in the Netherlands, 2 in New Zealand, and 1 center in Malaysia, which is at CVSKL, where this procedure can now be performed. So the take-home message: aortic aneurysms involving the ascending aorta and aortic arch should be replaced when greater than 55 millimeters. Early small aortic root aneurysms can be stabilized by personalized external aortic root support surgery. Aneurysms of the descending thoracic aorta are best treated by TIVA. Good blood pressure control can slow the progression of aortic aneurysms. So I think we have covered aortic disease. So this is just to remind us that obviously hypertension does affect other parts of the cardiovascular system. Coronary artery disease can progress with uncontrolled hypertension. So particularly if you have coronary artery disease, it is even more important to control the blood pressure. And you can see this is an example of patient with severe coronary artery disease. And as I mentioned at the beginning, we often do not realize this, but in patients with heart valve disease, it is very important to control the blood pressure. If for example, if the aortic regurgitation is not severe, if it's only just moderate aortic regurgitation or moderate aortic stenosis, then it is very important in those patients to control the blood pressure, because uncontrolled hypertension in those patients can accelerate the progression of the valve disease. Aortic stenosis and aortic regurgitation, there is now good data which show that if we do not control the blood pressure, then these can progress quicker than if we control the blood pressure. And similarly for those with mitral valve disease, and this also applies to patients who have had surgery. So after mitral valve repair surgery, for example, it is important to control the blood pressure to control the blood pressure to reduce the wear and tear on the mitral valve, so that the mitral valve repair will last the lifetime of the patient. And also after aortic valve surgery, particularly if the patient had tissue aortic valve replacement or bioprosthetic aortic valve replacement, it is important to control the patient's blood pressure to reduce the risk to reduce the stress on the valve. So this is mitral regurgitation. We won't go through this in detail. It's only to emphasize that we have to remember to control the blood pressure in heart valve diseases as well. In aortic stenosis, the same, and after valve surgery, the same. So I won't go through in detail how to control blood pressure, because that will be another lecture in itself. I think we would take too long if I were to go through this in detail, but I think I will just present to you to remind you about the guidelines for hypertension control. And you can see that the threshold for intervention is generally about 140, depending on the age of the patient. And this is blood pressure measured in the clinic. Remember that when the patient comes to clinic, to our outpatients clinic, generally the blood pressure is a little bit higher than when they're at home. So generally we will give some allowance for this before we would initiate treatment for hypertension. But generally, in most patients, if the blood pressure in clinic is above 140, then it does suggest that we should intervene to lower the blood pressure. And the target for this is about 130. This is from the European guidelines. If we read the American guidelines, they recommend a lower threshold to about 120. But I think in most patients, getting it down to about 130 is sufficient. Except, of course, if you've got specific conditions like aortic aneurysms or an aortic dissection, then we should aim for a lower blood pressure, probably about 120 to avoid major complications. And the various medications can be used to lower the blood pressure, and these are well published. Of course, if the blood pressure is not too high, then lifestyle interventions are important, and lifestyle intervention should be advised in all cases for patients to lower the blood pressure with restriction of the salt intake, avoiding excessive alcohol, increasing consumption of vegetables, fruits, fish, nuts, unsaturated fatty acids like olive oil, reducing the consumption of red meat, watching the body weight. Weight loss and exercise is a good way to reduce the blood pressure. And of course, not smoking. And for those who are already smoking, to stop smoking. And various classes of antihypertensives are available. The guidelines do suggest that as a first line, an ACE inhibitor or an ARB combined with either a calcium channel blocker or a diuretic are the best options to pick. And if there's still resistant hypertension, then you can add in a spironolactone or a beta blocker or other diuretics. But if the patient has got coronary disease, then generally we would add in a beta blocker as well. Or if they've got heart failure, then we would generally add in a beta blocker as a first line treatment as well. So this just summarizes the various drug treatments which we have available to control hypertension. And I think that's all I have today. I'd like to thank CVSKL and Servia again for organizing this, and I'd like to thank all of you for joining us today. I hope that it has been interesting and useful, and I'm happy to answer any questions you may have. You could type them in on whether you're on Zoom or on Facebook, and I will answer the questions.